what we're going to do right now is demonstrate how to perform a sacroiliac joint injection and a lumbar facet joint injection. Typical presentation is someone who comes into your office complaining of low back pain, perhaps going into the buttocks, the hip, or the groin, sometimes the thigh. On exam, they have discrete tenderness over the sacroiliac joint. So what you want to do is feel for the iliac crest, which is usually at the level of L4, right about here. You're going to palpate deeply and just follow the course of the iliac crest until you come to the posterior superior iliac spine, the PSIS. That's the most prominent portion of the iliac spine, or iliac crest. You're going to do a sterile prep. The agent that we usually use is a long-acting local anesthetic, bupivacaine. I use 0.5% without epinephrine, but you can choose to use epinephrine if you want to. And I use 40 milligrams of depomedrol, which is about 1 cc. So that's going to be in a 5 cc volume. I generally perform a skin wheel on the skin since that's the most sensitive area. From the posterior superior iliac spine, you walk off inferiorly, just slightly. Keep your fingers on the bone. Skin wheel is going to be medial to the posterior superior iliac spine. Always talk to your patient. You're going to feel a little pinch now, and then some burning for a few seconds. This is always the most uncomfortable part. That's why I prefer to have the patients lying down so that they don't have a vasovagal reaction and pass out on you. Okay, so I anesthetize the skin with a skin wheel using a 30 gauge needle. I then take my block needle, which in this case is a 22 gauge, 2.5 inch needle. I'm going to keep my fingers on the bone, the posterior superior iliac spine. I'm going to direct my needle from the medial to lateral direction. The patient should probably experience a deep aching pain. The needle should go into the joint space. You're going to feel it, sometimes a pop. You aspirate, make sure you don't get any blood or air, and then you inject slowly. The patient will feel deep pressure. And that's it. If you choose to, you can block the length of the sacroiliac joint, going from inferior to the middle portion to the superior aspect of the iliac crest. We're now going to demonstrate the lumbar facet blockade. The lumbar facet pain, again, typically presents as just axial lower back pain without any radicular pain into the lower extremities. Occasionally, pain from the lumbar area can go into the hip or thigh, but it doesn't extend below the knee. The procedure is done by palpating the spinous processes. The iliac crest gives you the landmark of L4. So that'll be the L4 level. The facet line lies approximately 3.5 to 4.5 centimeters lateral of the midline. I'm just going to draw up some agent here. We use, again, a long-acting local anesthetic, in this case Marcaine, 0.5%. You mix up your solution so that each level facet that you inject receives approximately 10 to 15 milligrams of depomedrol. So I am mixing 40 milligrams of depomedrol in about 7 cc's volume. So that'll give me about, let's see, okay, need a little bit more. So 80 milligrams in 8 cc's is 10 milligrams per cc of depomedrol. Most pain in the lumbar area from the facet joint is in the lowest levels, L3-4, L4-5, or L5-S1. There is overlap of the innervation of the facet joint so that at each level you get a supply from the level above and the level of. So at L4-5 you'll have innervation from L4-5 and from above L3-4. So you feel for the spinous process. You're going to go approximately 1.5 inches lateral to that. Tell the patient you're going to feel a little pinch here, a little burning. Again, the skin wheel is done with a 25 gauge needle. How are you doing?
Fine.
Okay. Always communicate with your patient. The needle is then going to, I'm using a 25 gauge 2.5 inch needle. The needle is then going to go straight down until your contact is made with the bone. If you wish to try an intra-articular technique, then you will direct the needle slightly medially. You want to avoid going too medially where you might risk injuring the nervous structures, or too laterally where you will potentially injure some retroperitoneal structures. So I'm going to go straight down until contact is made with the bone. The patient should experience some deep, dull, aching sensation now as the needle approaches the correct area. You aspirate and then inject approximately 1.5 cc's, no more than 2 cc's at most. Now the L5-S1 level is generally more difficult to do because of the lumbar lordosis of the lumbar spine and the position of the iliac crest. I will do the L3-4 level, which will be just above the L4-5 level. Again, in the midline you feel for the spinous process right here. Inject the skin wheel about 3.5 centimeters lateral to that. Little pinch and some stinging. Then I'll take the 25 gauge 2.5 inch needle, and again go straight down until contact is made with the bone. Aspirate and inject about 1.5 cc's. Now afterwards, it's important to let your patient recover in the lying down position until they feel comfortable. Then slowly we can ask the patient to sit up if they feel fine without being lightheaded. We will give them general instructions, go home, rest, put ice on the affected area. Some people can get an inflammatory response just from the needle manipulation. Ice for 24 hours, and then they generally should feel better from the steroid effect of the injection within 72 hours as the local anesthetic effect wears off.